Good morning. Good morning, everyone. Whew, welcome to the 4th Annual Executive Performance Improvement Summit by BAPIN. This is a really exciting event for everyone involved, and I have promised the speakers and everyone else that I would keep the non-value added, yet necessary non-value added comments to a minimum, and I'm actually going to save those comments until after our keynote and executive panel. So, but one quick housekeeping question before we dive into our keynote presentation. If you have an empty seat next to you, please raise your hand. Okay. Noted. So as people trickle in, we will try to direct them to those seats. Okay. With that, I'm going to make 2 very brief introductions. All of the introductions today will be brief because you have all of the bios printed for you at your tables. So if you're interested in learning more about any of the speakers, please take a copy of that with you. And it was also emailed to you, so hopefully you have that in your inbox in a PDF. Emailed just yesterday, so after this lovely weekend, you might not have seen it just yet, but it is there waiting for you. So 2 quick introductions. First, I'd like to introduce Thomas Rundle. Tom comes to us from UC Berkeley. He's faculty emeritus there with the School of Public Health. He is also the co-director of CLEAR, which is the Center for Lean Education and Research. We are very fortunate to have Tom to moderate the executive panel that will follow the keynote. So once I'm done talking, I'll hand the mic over to our keynote speaker, and then Tom will take over from there. So thank you for joining us, Tom. Now, without further ado, I'd like to introduce Richard Shannon. We are very fortunate to have Rick here. Rick is very skilled, very knowledgeable, very experienced in the pragmatic leading of lean and performance improvement, performance excellence with organizations in other regions of the country. He comes to us from the University of Virginia Health System. Please read his bio. It's pretty phenomenal. He's been featured in CNN. He's been featured by PBS in the remaking of American Healthcare documentary. We are lucky that he happens to be in the area for a Kaiser board meeting today. So we're fortunate to ride on the heels of that meeting. So, Rick, thank you very much for joining us, and welcome to the Executive Summit.
Thanks, Steve. Thank you. I really appreciate the invitation when Steve and Jeff Webster, who I've known for 17 years on this journey, suggested that you guys were going to be having this annual meeting and that I might have a chance to share some ideas together with you. It was absolutely something I couldn't pass up, even though it meant getting up at 3 a.m. this morning to get here. So if I stumble a little bit, please forgive me. But it really is great to be here. And as I also said to Steve and to Jeff when they invited me, if the Bay Area can pull together and implement these ideas around performance improvement in healthcare, then anything really is possible. Because I think that our nation looks to this area for innovation and creativity and thinking about new ways forward. And if those ideas can extend to healthcare reform, I think it would be an extraordinary achievement. So I would never miss the opportunity. So just to, by way of full disclosure, I have the privilege to sit on a number of boards, including the Kaiser Foundation Health Plan and Hospitals. I also sit on the board of the NIH Clinical Center. So you couldn't think of 2 more disparate organizations. The NIH Clinical Center is the nation's largest hospital dedicated exclusively to research. So think about the quality issues there compared to a large integrated delivery system like Kaiser. But I've also had the chance to work with the Association of Academic Health Centers, trying to convince leaders of academic medical centers to embrace the ideas, and done a lot of work with Don Berwick and IHI, as I know many of you have. I want to frame this first and foremost in the context of healthcare reform, because I think the rising cost of healthcare, even in the wake of reform, is creating untenable social choices. And those social choices are really beginning to impact our culture. So we spend a lot on healthcare, 18% of the GDP. People say that. That means you actually have to understand what the GDP is, which, you know, I won't try to define from you, but it's a lot of money. Somewhere north of $3 trillion. It accounts for much of the federal spend. But here's the important piece of this story. We spend 8 times more on healthcare than we do on education. So when we wonder why American children are falling behind, or why the price of higher education, tuition, continues to rise, one can draw direct connections to healthcare. So in Virginia, where the state of Virginia is 41st among all states in the union in supporting higher education, the consequence of the rising cost of healthcare is less state support for tuition. And that means passing the cost of tuition on to parents and families, which contributes then to the second epidemic crisis in America, the issue of access and affordability to education. So just you know, a sort of subtle connection between two forces at tension, particularly at a state level. And then you can pick your social good: food, the environment, law enforcement, defense. They are simply overwhelmed in terms of the amount we spend on healthcare. Now, that has led to healthcare reform, which is sort of a experience through which we've all passed over about the last 5 or 7 years. And a couple of points I want to make about this is, first, despite what you might think, healthcare reform is not of a political making. And I know that sounds incredible, but it's not of a political making. Healthcare reform is a product of two forces. One, the changing face of human disease, where we've moved from human disease being a series of infectious illnesses, treatable or not by a period of antibiotic use, to a circumstance now where Americans, particularly older Americans, but Americans of every way, shape, and form, suffer from chronic conditions, which means they are continuously interacting with the healthcare system at higher and higher expenditures. Caring for someone who is diagnosed and treated for cancer and survives is a very different economic proposition than taking care of someone with scarlet fever. And it's only 25 or 30 years since we've seen that dramatic shift in the biology of human disease that is causing us to rethink about how we deliver care. And then there's the demographic, which I'll spend some time talking more about. And in the course of reform, there are all these new terms that have been introduced, most of which I would argue are simply masquerading as cost-cutting endeavors. First, population health, something which I think held great promise when the idea was evinced 5 or 7 years ago. But it turns out is now really a euphemism from simply moving risk from payer to provider and from provider to patient, right? High deductible health care, cuts in reimbursement where the provider community is asked to share risk with an insurer over a population. I think of population health as investing money in wellness to prevent disease and managing episodes of care in a highly efficient way. But population health has become this euphemism for really reducing what payment occurs to providers, and then to providers figure out what they do with their patients. So when you're dealing with that kind of pressure and you're a leader of a healthcare organization, you have to figure out a way to rally the troops. And we've used 3 different narratives to really engage our workforce in what we think is a much more positive view of reform. First is, don't focus on payment reform. There are hundreds of payment reforms. You could spend your life trying to figure them out. And as we've seen with a stroke of the pen, the president can undo many of them. Focus on practice reform. The idea that embedded within what we do, what we control, is an economic opportunity that may approach a third of the total spend on healthcare. Secondly, whatever your specific system, Lean, Six Sigma, or of your own making, clear, whatever the system, just drive value by getting really good at what you do. And by that we mean provide what a patient needs when they need it, on time. How about that? On time, the first time, no defect, no error, no waste. That is driving value through process excellence. And that is what we control as providers. That's the part of the story that's ours. And that's the part that we need to become serious in our undertaking. Now, the demography is an irresistible force that is having the biggest impact on healthcare reform. And I begin with this iconic image in 1965, 50 years ago, the Medicare Trust Fund Act, arguably one of the greatest pieces of social legislation, Social Security, Medicare, the Affordable Care Act, all great pieces of healthcare legislation. And in this image, you'll see President Johnson signing the Medicare Trust Fund, and with him, President Truman and his wife, Bess Truman. And President Truman is here because he was actually the first recipient of a Medicare card in 1965. But what's most notable about this is what President Johnson said on that day. No longer will older Americans be denied the healing of modern medicine. No longer will illness crush and destroy the savings that they so carefully put away for a lifetime that they might enjoy dignity in their later years. No longer will young families see their own incomes, their own hopes, eaten away because they're simply carrying out a deep moral obligation. An extraordinary opportunity to provide health care for all in retirement. And of course, the Affordable Care, 50 years later, was designed to provide health care for all. But from the moment of its inception, Medicare was financially in trouble. In 1965, there were 20 million Americans who were Medicare beneficiaries. The average cost per beneficiary was $267 per cap. There was no risk adjustment in those early years. The actuaries predicted that people would live an additional 3 years beyond the age of 65. And there were 5 working Americans for every 1 retiree paying into the trust fund. And it was in arrears in year 1. What was paid out as Americans, older Americans, for the first time had access to health care ended up being 4 or 5 times what the actuaries predicted. And since that day, the trust fund has been playing catch up. But now, fast forward to 2017, where there are 45 million Americans, twice as many people 50 years later. The average spend, $8,300. The average life expectancy, 77 years. No adjustment in the actuarial model, but now living 10 years longer than projected. And about 2.5 to 3 workers paying into the trust fund for every beneficiary. And then here's the crux. What happens beyond 2017 to the year of 2027, where there'll be 90 million Americans, so a doubling of the Medicare population in the next 10 years. Only 2 workers paying in, and the average per capita cost expected to rise to almost $11,000 on a risk-adjusted basis. That's what creates the crisis of healthcare reform. The government has no way of paying for it. And yet we've made this promise a real reality. And to put that reality in its starkest terms, here's a piece of economic data. And again, I'm not an economist, but I think this is simple enough for anyone to understand. In the blue line is the total revenue into the U.S. Treasury. Every dollar that pours into the U.S. Treasury. And the red line is what the government spends on 4 programs: Medicare, Medicaid, Social Security, and the debt. And what you see about 2017 is that the red line exceeds the blue line. That over the next 10 years, the doubling of the Medicare population and the growth of the Medicaid population is expected to consume all of the disposable income that the federal government takes in. Meaning, no money for education, no money for defense, no money for the environment, no money for you name your social good. Unless one of two things happens. One of three things, I guess. We raise taxes, we cut expenditures, or we borrow more money. Those are the only three options. So when you say, why do we find ourselves in this moment of this crisis? It's this. It's this. That the demographic and the social obligation we hold now put us at the brink of what will truly be a fiscal crisis, unless we do one of those things, none of which are particularly popular, right? Cut payments, cut benefits, increase taxes, or borrow more money. And as you might imagine, thinking about those things in Washington, D.C. terms, and I live 90 miles from the nation's capital, I can almost feel the tension, is not a likely outcome. So the consequence is the government has done what it can only do, and that says we must cut what we pay for services. Think about it. No politician is going to cut benefits to older Americans. They're the largest, most high-fidelity voting group. We have seen that the government is willing to cut benefits to Medicaid recipients, largely because they don't vote en bloc like Medicare recipients do. But the government is wantonly cutting payments for services in Medicare and Medicaid. And I'm sure those of you that are responsible for this part of your business can appreciate this, but the Affordable Care Act was paid for through a series of payroll and taxes on certain goods like device taxes and Cadillac taxes, which never actually went into effect. But it was also paid for in years 17 through 23 with cuts to Medicare. So I don't know about you, but we are seeing over the last year, this year, and next year, $150 million in actual reductions in payments for the same Medicare services we provided 2 years ago. It's over a 3-year period. Now we have a revenue of about $2.1 billion, but $150 million in Medicare cuts is a big deal. And I'm sure in some way, shape, or form, you are facing the same. Now, that would be a responsible thing to do, except for the fact that it has a limited outcome. That when you start to reduce what you pay providers in a very extreme way, providers stop caring for patients that need their services. So just to the south of Virginia and North Carolina, 40% of primary care doctors are no longer taking Medicare and Medicaid patients. When you cut reimbursement, you create a crisis of access. Only those that can afford to pay get care. So cutting is not a way forward. It is a short-term way to try and change the slope of that curve. But it is not a long-term way forward. And that's why you hear the Congressional Budget Office saying, okay, the doomsday may not be 2017, maybe it'll be 2018, because the cuts are just pushing it out a little bit, but it's not fundamental reform. The fundamental reform that can truly change the landscape of U.S. healthcare is to improve our way out of this, eliminating defect, error, and waste in the way care is delivered. And that's the work you're about. That's why it's so important. That's why the Bay Area can be that place that becomes the national demonstration, the place that we've been seeking for 15 years, and some of members of this audience longer. So I'm going to turn my attention to improvement in just a second. But I want to talk next about the other pernicious influence, well-intentioned but pernicious influence, that this form of cutting has created. And that is the idea that public reporting and quality measures has become a tyranny of our world. The idea that measurement so consumes what we do without real effort on improvement is an issue. And I point this out, what I call the honor roll mentality. What measurement under the current circumstance does in terms of advancing quality is debatable. But what it has created, this idea of have and have-nots, right? So if you can afford to go to the Mayo Clinic, turns out it's a great place. The honor roll mentality says that there are 15 great places or 50 great places in America, and those of you that have to go to any of the 3,500 others, good luck. That's not a way forward. That also contributes to the haves and have-nots. If you can get to one of those places, try getting to Rochester, Minnesota, right? It's not easy. If you can get there, then and only then do you get great care. That's not workable. That's not workable. Every place has to get better. Every place, because Americans can't travel to the Mayo Clinic, most Americans. But this is this idea of those of us that are in academic medicine and, at distinguished universities like Berkeley and UVA, we pride ourselves on these intellectual environments. But the question is, do we in healthcare ever do anything that vaguely resembles being a learning organization, right? Something new, something we actually acknowledge we didn't know about the way to deliver care. So I would characterize my organization as a fledgling learning organization. But this is the organization that I inherited. We were infatuated with reporting but not acting on our data. Totally consumed in counting line days and bed days and dead days and live days and not acting on any of it. Dutifully reporting. We were awash in things that no one could understand. 1,700 NQF quality measures. Really? We lacked no common discipline problem-solving system, which meant that when a metric moved, it was simply the Hawthorne effect. Watch it for a little while, it'll change, it'll come back. This is an academic medical center, right? Ostensibly a learning organization. There was absolutely no room for learning in any executive's life. It was either you know it by the time you got to the C-suite or that was it. As if once you somehow become a CEO, you become brain dead. As opposed to that should be the most fruitful time of your career to learn everything it is new about your organization and how to do things better. But in my day, if you were to look at my schedule, there was no room to learn. I was consumed in meetings that added no value to anything anybody was doing and completely occupied my time, to the point that Steve made early on, to value less time. Would anybody be willing to pay me to go to those meetings? And the answer is no. And then, of course, the great thing academic medical centers do, we confuse effort with success. If you're working at it, it must be getting better. So this is the state of affairs in my organization 3.5 years ago, and I would submit the state of affairs in many organizations today, even many years into a quality journey. And it reminds me of this cartoon, right, which shows these poor guys in the stern of the boat bailing and two guys in the front saying, "I'm sure glad the hole isn't in my end." This is the problem with the honor roll mentality, that if only a few academic centers or a few places around the country are said to be great, what about those that aren't? And by the way, isn't the whole ship taking on water? And to the issue of tyranny of measurement, I turn your attention to something that I think is the quintessential example of how far wrong we've gone in measurement. So at the University of Virginia Health System, we report 484 measures annually to 13 different regulatory agencies. It costs $13 million of operating income every year to report it. Honestly, we report them all dutifully. We focus on 5 or 6 of them at a time. And my favorite is mortality. We report our mortality to 8 different agencies. And if you looked up UVA Health System in those 8 different agencies, you'd find 4 different mortality rates. How can that be? If you're dead, you're dead. There is no arguing with the definition. How could there be 4 publicly reported measures of who's dead at UVA? And of course, the one we believe is the one where we look the best, right? This is the quintessential example of what tyranny measurement has become. Preoccupying the workforce in measurement, not action. And this, reminds me of this cartoon, right? Your proposal was second to none. We chose none. There's no way of winning at this. No way of winning. You can be great in one and average in the other. This is an example of a screenshot from the University Healthcare Consortium, UHC, now called Vizient, which we participated in when I was the chairman of medicine at Penn and I first got interested in mortality. This is a screenshot of the data reported quarterly on who died at Penn in the Department of Medicine. It's not so hard to figure out. But this is the massaging that goes on. And you may not be able to see it. The blue line is the actual number of deaths. And our observed to expected ratio wasn't what we wanted, wasn't as good as we wanted it to be. So what did we do? We hired more coders to increase our expected mortality so the ratio would go down. Now, I never saw a coder bring anyone back to life. And what is it about coding why a person died 30 to 60 days after they died? My next cartoon. He's one tough cookie. I've never seen anyone bounce back from an autopsy. The concept is that clinicians and providers know when a person dies, why they died, and whether it was expected or unexpected. And that is data that can be collected every day and counted in single digits. And I think every CEO ought to know how many people died in their organization year over year, and how many of those deaths were expected or unexpected. That's it. And you ought to know that year over year, you're getting better. That's all. The simplest thing to do. Every day in my organization, we meet in a situation room, and the first thing we discuss is who died yesterday. And we pay homage to them. This was, 65-year-old grandmom who had lung cancer with brain mets, who came in, got comfort care, and died. And then one question, was it expected or unexpected? And that's a simple one. When the healthcare provider left last night, did they expect the person to be dead this morning? And anyone that says, boy, when I left last night, I thought this guy was going to be okay, that's an opportunity to figure out what happened. It's simple. It's simple. And that's the way we look at mortality. And then you have the billboards, right? And, I can't say that I don't look at these rankings. I do think that, you've got to do a little scoreboard watching when you're in the business. I understand that. But this is the framing of a great study that was published in Health Affairs, which looked at rankings in Leapfrog, Health Grades, Consumer Reports, and U.S. News. And many of you may remember this, but I'll just read from the abstract in the box. No hospital was rated as high performing by all 4 national rating agencies. No hospital. Not all those 4 journals, they all didn't pick the Mayo Clinic. And in fact, only 10% of 844 hospitals ranked as high performing by one of those magazines was ranked as high performing by the other. And this is the reason why most people choose their healthcare by looking at Angie's List. Because this is completely uninterpretable. And oh, by the way, how do you think these magazines do this work? Through the marketing that they sell if you get to be a top 50 performer, right? Or whatever level you perform at. Not quality. This is not quality. This is not process improvement. This is the tyranny of measurement. And then finally, the recent CMS litany of to-dos, right? So this is another article, which I think this is from, I forget, JAMA. Among hospitals participating in the health infection reduction program, hospitals that were penalized more frequently had more quality accreditations, offered more advanced services, were major teaching institutions, and had better performance on other process and outcome measures. These paradoxical findings suggest that the approach for assessing hospital penalties in the HAC reduction program merit reconsideration to ensure that it's achieving the intended goals. It is a tyranny of measurement masquerading as quality. So how do you move forward? Take a simple construct. Don Berwick's 6 levers of waste. Harm, overtreatment, defect in care delivery, defect in care transitions, excess administrative costs, fraud and abuse. And let me, for the moment, dismiss fraud and abuse, because it's small. We like to focus on it, but it's small. The big ones are harm, overtreatment, defect in care delivery, defect in care transitions. Those are the big ones. And then, how do you wrap someone's interest around waste and its removal, or defect and its removal? I can tell you, you don't do it by counting line days. You do it by faithfully reporting every day everything that went wrong with respect to a safety event. And I'm not talking about a sentinel event. I'm talking about any near miss that occurs in your organization. So I think the journey begins with safety because it's easy. It's unassailable. It violates our professional duty. It's the most elementary form of waste. It's valueless. It can be eliminated. Please raise your hand if you'd like to get a hospital-acquired infection, right? No one ever says yes. The safety is the quintessential example of waste, which is why I think it's the fundamental starting point for a journey in high performance. And it's still a problem, right? Still 5 to 10% of people in American hospitals have a hospital-acquired infection. Lots of infections, lots of deaths, lots of cost. And of course, the paradox is this. This is an Alcoa aluminum manufacturing plant in Alcoa, Tennessee. Now, if you want to know how important Alcoa is to that community, they named the town after the company. They make hot molten metal at 2,000 degrees on 3 football field long conveyor belts with 2-ton things flying overhead. The average age of the workforce is somewhere around a high school. I'm sorry, the average education is somewhere around high school. And this is a U.S. hospital. And so the simple question I have for you, which is safer? To work at Alcoa or to walk into a U.S. hospital? It's 27 times safer to work at Alcoa than the average U.S. hospital. What is that all about? They make hot molten metal at 2,000 degrees. So that's why safety, I think, is a great starting point. Now, in the panel discussion and later, I'm going to talk about how we did this. But let me tell you that you can go fast to get really good outcomes if you do a couple of things. A, if the CEO owns the result, not the chief quality officer, not the person responsible for infection control. If the CEO owns the results and says to the board, I will be evaluated on my performance against these measures. And when the board just says, well, what about the finances? What you say back to them is, if I get this right, the finances will follow. And I'll show you that. So when we began in 2013, we had to create new structures, we had to create new systems, and we had to create new work processes in order to get this work. But they fell into pretty clear buckets. When it comes to placing a device, there are only 3 pieces of standard work you need to command. How is the device placed? How is it maintained? And how is it manipulated? So whether it's an endotracheal tube, a surgical wound, a chest tube, a urinary tract catheter, a central line, a peripheral line, Anything that goes into the body, how is it placed in a standard way, how is it maintained in a standard way, and how is it manipulated in a standard way. And when something goes wrong with the device, like an infection, a breach in any one of those three processes is the root cause. But if you understand how that work is done, you can go back and figure out the root. The second thing is the CEO, first CEO has to own it. Second thing, there has to be standard work that's created by the workforce, not by the CEO. The third thing is you have to report it every day. Every day. Any event that's associated with an untoward outcome in any of these categories, you could list your own up there. But note, I don't see any line days. I don't see normalization. I don't have 10,000 people sitting in the basement of the building counting line days. What a job. I met the lady in our organization that actually counts line days. I said, you poor soul. What kind of work is that? What if we elevated you out of the basement of the building and said, you're responsible for bloodstream infections? Adds meaning to someone's life as opposed to sitting, looking at a chart trying to figure out how many line days there were. So this is sort of an example. Bloodstream infections in 2013, we had 118. Last year, June 30, we had 15. 1-5. Now, how is this done? Today at UVA, if you have a central line and you have a positive blood culture, at that moment, within 24 hours, all the details around what's that blood culture related to are completed by people on the front lines. Every unit has a bloodstream champion that the minute there's a positive blood culture, we don't wait for infection control to tell us it's a bloodstream infection. In fact, we try to take the decision out of their hands. We say, wait a minute, we know that bacteremia is due to something else. So it positively engages the workforce to take control of this. But it means actually looking at every positive blood culture every day. And then matching that up on the unit, because on the unit, it's clearly identified every patient that has a central line. Visible to everybody on the unit. Who's got a line today? Does that match up with a positive blood culture? Bing, investigate. Placement, maintenance, or manipulation. Same for urinary tract infections. I put an asterisk next to urinary tract infections because 18 of those 21 infections occurred in people with dysfunctional bladders. People that had to have a chronic Foley, where taking the Foley out isn't the option, right? So we've had to learn a whole new way. How do you manage people that need a Foley for their life or have a suprapubic tube? That doesn't fall neatly into version 1 of placement, maintenance, and manipulation. So you learn new things. You realize that all your defects are suddenly aggregating around people with dysfunctional bladders, and then you can figure out how do we deal with those guys. Bladder scans, intermittent catheterization, lots of different things to try and test to keep the catheter out. C. diff, I put an asterisk next to this one. This was a total issue of doing too many C. diff tests. So we have house staff in our organization. Anytime someone had a loose bowel movement, C. diff. And for those of you who know anything about the C. diff test, it's a DNA test. And so like 1 microspore of C. diff lights up the PCR machine like the person is going to die from C. diff. And those were all getting counted. But today, there's standard work before you order a C. diff test, like 3 loose stools and on no laxatives. I don't know how many people had diarrhea because we were giving them laxatives and we were testing them for C. diff. But you look at the whole work and you begin to discover this. This is just reduction from not ordering unnecessary C. diff tests. We didn't have an epidemic of C. diff, we had an epidemic of ordering. Now you've got 56 cases you got to get serious about. Cleaning the rooms, making sure your antibiotic stewardship is good, making sure you're doing your ATP tests on the surface, whatever the work is around that. But you had to get rid of the noise. And think about it. I know many of you work in places with house staff. Anybody checking to see how the house staff are ordering C. diff tests? So the house staff take great credit for this because we're able to show them the data and say, please don't order C. diff tests on someone that you're given a laxative to. That's the desired outcome, diarrhea. So you get what I mean, right? So, but you got to look at that every day. Now, you can say, okay, does this guy really mean every day? I can show you on my phone. It'll take me a second to pull it up. Every day, no matter where I am in the world, this report comes up. The first report I get is on our preparedness, green or red. Do we have all the people and all the services in place today to meet our patients' needs? nursing, pharmacy, respiratory therapy, ambulatory clinic, registrars, everybody across the organization. So it's Tuesday after a holiday weekend. I don't want you to think it's always green. So could be the best case scenario. But every morning before we start in the situation room are we situationally aware of what's going to happen today? How many OR cases? How many beds do we need? What's the throughput through the OR? When are the afternoon cases supposed to start? That's the situational awareness. And then the other sheet I get is this one. Anywhere I am, I can't hide. This is events of yesterday. 2 deaths, 1 team member injury, 1 pressure ulcer, 11 patients who should have been screened for a DVT prophylaxis that didn't get screened. Every day. And then I can click on this and it gives me an update on what the cases were. So I'll turn to mortality. In 2013, we had 813 people die at the University of Virginia Medical Center. This year, 692. Our acuity is up, our volume is up, but there are fewer people dying because we are focused on eliminating complications. And the numbers in parentheses, there were 79 people in 2013 that died unexpectedly. That means we did something to them that caused them to die. In 2017, 13 patients. I don't care what the mortality rate is. I want to know what happened to every human being and why. And then that becomes the opportunity to learn. HAPUs, team member injuries, big deal. It's really hard to engage your workforce if you're not interested in them. And one of the ways we've demonstrated our commitment to our workforce is by really looking at team member injuries. Now, we haven't made great movement here. That's because reporting has gone up. But I can tell you the 4 most common injuries our workforce are sticks, exposures, ergonomic injuries, slips, trips, and falls, and then being hit by a patient. Our nurses get hit a lot by patients, struck by patients. I couldn't believe the number of instances, over 100 instances of nurses being struck by patients. How can I possibly profess interest in and respect to my nurses if conditions are such that a nurse can be struck by a patient? So you have to get your hands around that. But the DART, which is the sort of occupational measure of this, has gone from 6.13 to 3.05. Now, just to give you an example, I think Alcoa is what, 0.27 or something? So when I say 27 times safer, in 2013, we were 30 times less safe than Alcoa. And today, we're sometimes somewhere around 10 times less safe than Alcoa. So you can measure these things as a way to move forward. But it's every event, every day, with people committed to understanding what happened and a commitment to make sure it doesn't happen again. And it doesn't happen overnight. That's a 4-year journey. The other thing about this is it's hard work. And so you have to recognize early on that you have to be resilient and gritty in your pursuit of this. Now, I began by saying if you eliminate harm, maybe we can fix healthcare. So what's the evidence that fewer infections result in less spend? So this is actually from the Pennsylvania Healthcare Cost Containment Council, a board on which I sat when I was at Penn in 2013. So this is 163 hospitals in Pennsylvania. They had about 2 million people admitted to hospitals, and 23,287 of them had a hospital-acquired infection. You see, in Pennsylvania, it is a statute, a state statute, that all hospitals must report hospital-acquired infections. And if you don't, there is a very serious penalty, including loss of license. So it's a serious thing. So 2 million people admitted to Pennsylvania hospitals, 23,287 get an infection. So if you were one of those people that got an infection, your mortality was 9.4%. If you're one of the people that didn't, it was 1.8%. If you got an infection, you stayed in the hospital for 22 days. If you didn't, you stayed for 5. Oh, and by the way, you were readmitted in 30 days 40% of the time if you had an infection versus 16% of the time. You want the quickest way to reduce your readmission rate? Eliminate your hospital-acquired infections. These are recurrent issues. And then it cost Medicare, these are Medicare dollars, $20,471 for patients that incurred an infection versus $6,600 if you didn't. That's a $13,000 swing per case on average. And you can see the costs vary by different types of infections. So if you take $13,000 per infection and multiply that by 23,287 infections, that's $327 million consumed in the Commonwealth of Pennsylvania in infections. That's money that can be made available to care for people that don't have insurance. And this is but a fraction of the opportunity. But $327 million in Pennsylvania, we estimate it's close to $300 million in Virginia. I have no idea what it is in California. But let's just say a multiple. So where are we going to get the money? Isn't that a better course than cutting what you get paid for a primary care visit? Or for a colectomy, or for saving someone's life in your OR? Now, the second thing I want to focus on in dispelling the tyranny of measurement that was critical to our organization's engagement was to ask the question, what matters to you in terms of measurement? So we went around our community and held consumer focus groups. We went to the millennials, and we went to the Senior Citizen Center, and we went to the Board of Education, we went to the Chamber of Commerce, we went to the county, and we said to the employees, we said, so tell me, if you were me, what would you like to know about your healthcare system? And I said, Dr. Shannon, we don't know anything about those line days. What is all that stuff? You keep talking about it. That's not. I want to know, if I come to you for care, what's my chance of surviving? What's my complication rate, and when can I go back to work? I want you to tell me those three things for everything you do. And of course, that was an interesting pivotal moment, because we were able to go back to our doctors in particular and say, hey, guess what? Our public would like to know how good we are at fill in the blank. Normal vaginal deliveries, 5-year survival from lung cancer, post-op cabbage surgery, gallbladder resection, DVT, you name it. The public would like to know, how good are we? Are we getting better? What's our complication rate? When can I go back to work? So we totally turned the measurement system on its head and started measuring clinical outcomes. Now you had the doctor's attention, because you were reporting on how their service lines were doing, and you were reporting it referable year over year, and how they were comparing to some kind of norm. So here's an example. This is angioplasty following acute myocardial infarction. What's your chance of surviving at UVA if you have a heart attack and you have an angioplasty? And so in 2015, the mortality was 4.1% at UVA, compared to 6.6% in 257 other hospitals in the Mid-Atlantic region, reporting their clinical data to the American College of Cardiology. So our clinicians were already reporting these to their professional registries. We were just looking at them. And then, so, you're about 40% less likely to die if you got your infarct care at UVA. And then we said, okay, can we get better? So a year later, the mortality was down to 3.67%. Compared to 6.67%. So how was it done? It was done pretty simply. We made an investment at the suggestion of the emergency room doctors to put EKG machines in all the ambulances in Albemarle County. So they came to me and they said, what? I said, what? You want me to buy EKG machines for the ambulance drivers? They said, that's exactly what we want you to do. So we did. So now, telephonically, anybody that's having a heart attack, we know about before they arrive. And that means our door-to-needle time is 42 minutes. 42 minutes, not 90 minutes. And that's the difference between this and this and this. The second thing was to meet with the orderlies who are responsible for transporting patients from the emergency room to the cath lab, and saying, you are the most important link in saving this human being's life. I need you to do this well every time. And they would say things like, I'm just an orderly. I said, no, you are principally responsible for saving these people's lives. Because if they don't get to the cath lab, doesn't matter. They said, do you mean that? And I said, these are your results. You are this. This is the orderlies. A year later. They're worth a percentage point in survival. And they go home at night and say, guess what? I'm not an orderly. I'm part of the acute MI team that saves lives. What about complications? These are data we were collecting as part of registries. I'm sure many of you participate in these registries. Clinical registries, not billing data. These are data put together by professionals who look at complications in real time and then report it. And then the data come back to you. The only problem is we weren't looking at it. But it's clinical data. What about complications? So 2015, you were 50% less likely to have a complication following your heart attack at UVA than if you had it in 257 other centers. And oh, by the way, those centers spanned from Philadelphia in the north, west to Nashville, over to Pittsburgh, and down to Atlanta, and include Baltimore, Maryland, and Durham, North Carolina, and a number of other pretty big places that surround us. And a year later, we went from 7.5% complication rate to 5.8% complication rate. What was that all about? Well, as it turns out, these are the 4 most common complications following a heart attack. This is 2 years worth of data, more than 1,500 heart attacks. No bleeds in 72 hours following the procedure. No requirement for dialysis and no strokes, and half the incidence of heart failure. So what did we do? We went to doing radial artery catheterizations on all patients. Our cath lab guys got really good at using the radial artery so you don't use the femoral artery and you don't bleed. This difference in complication rate is about a $4 million savings between having a complication and not having a complication. Please raise your hand if you'd like to bleed after your heart attack, right? These are really, really meaningful outcomes with respect to what patients want and what you can save. And I can go through all these. I'm not going to go. This is CABG surgery, coronary artery bypass surgery. UVA, hospitals like UVA, and then the national average. So your chance of dying of an operation for CABG surgery at UVA is 0.7%. How? We have done everything humanly possible that we know as of today to streamline the process from the minute you're scheduled for surgery to the day you leave. An entire value stream map of what constitutes each step, totally redefining the process, totally redefining the postoperative care. And it's not just in-hospital mortality, because I'm really not happy if I just don't die, while I'm in your care. 30 days later, our mortality is the same, the national numbers go up. So care after you have your operation becomes really important. And I'm going to go through this quickly, but I want to give you some other examples. Major complications from surgery. We're a little bit better. We're not as good as we are with heart attacks, but we're a little bit better. And each of these is associated with a cost savings. People stay less time in the hospital, they spend less money on supplies, spend less money on valuable professional time. So clinical outcomes can create this focal point for really thinking about improvement that your workforce can really understand. Because let me tell you, this has the surgeon's attentions. I just want to say one other thing, because you'll hear our team talk a lot about the theoretical limit. So let me ask you this. If the mortality today is 0.7% from CABG surgery, do you think 0 is possible? Think about that. 0. I showed you. Oh, I got my clicker wrong. 0 is possible with respect to bleeding, dialysis, stroke. Is 0 possible with respect to mortality in CABG surgery? I think so. 0.7 for us is like 19 deaths. And when we look at those 19 cases, the most common thing we find is, probably wasn't a good idea to operate on that guy. Pretty sick. So there are ways you could think about this. There are ways you could learn from each of those. And our surgeons are fixated on that mortality now. So in any event, I think just an example of how those things could work. Let me get going in the right direction here. All right, I'm going to show you a couple other examples. Cancer. Cancer. People in Charlottesville want to know, what is my 5-year survival from lung cancer? And I would usually say, boy, I don't know. I'm sure we're good. I'm sure we're good. But I don't know. You look up the 5 top cancer centers in America on their websites and try and find out what the 5-year survival from lung cancer is. Well, this is the 5-year survival from lung cancer at UVA, and this is compared 2006 to 2012, then 2012 through 2015, the most recent data. And this is compared to national averages in the National Cancer Prevention Program, put together by the CDC. Now, these aren't perfect data. They're not stratified by stage at presentation, but it's something our cancer doctors can focus on. So there's some things like colorectal cancer where we haven't really gotten much better. We're about at the national average. And there's things like lung cancer, where your 5-year survival from lung cancer is twice the national average at UVA. And getting a little bit better. So now we have a fertile basis for service lines to look at their work and say, if I wanted to increase survival from colorectal cancer, what are the 2 or 3 redesigns in the way we do our work? I'm going to do this. And this has an interesting implication, because the best way to reduce mortality from colon cancer is to screen for colon cancer. You move the whole workflow upstream into the ambulatory arena. That's the best way to get a 10% improvement in mortality from colorectal cancer. Find it. All these interesting aspects of improvement that come by looking at clinical data. All right, I'm done. Yeah, I'm done because we have to talk. I could show you lots of evidence, but suddenly this is colorectal surgery, where we were looking at using ARIS, early recovery from surgery. I know many of you have looked at this, but this was putting ARIS on steroids, making sure that every patient was part of the protocol for early recovery from surgery. And you see what happens is length of stay goes down, readmission goes down, surgical site infections go down, CAUTIs go down, other postoperative complications go down, opioid use goes down, satisfaction goes up. So here's satisfaction with pain control. Prior to ARIS, 11th percentile. After ARIS, 99th percentile. So you want to boost your communication with nursing, rate top box, whatever those things are. Get really good at how you take care of people having colorectal surgery or having hip surgery or having colectomies or whatever it is. Because people experience it. Look at these numbers in terms of improvement in satisfaction. People know when you're engaged in that kind of improvement, and they experience it. And again, when they don't have complications, the biggest driver of dissatisfaction is a complication. And that's something the workforce can really gravitate to. So we've stopped perseverating on the 484 measures and started looking at every clinical service line. And using lean thinking and value stream mapping and input from patients and providers. How do you redesign that work? How do you look at every complication every day and figure out how to do it better? Not punitively, but with the goal that zero's within your reach. All right, I'm going to end on this, and then we're going to talk, right? Is that are we somewhere on time? Oh, beautiful. We can talk a little bit about method. All right, so here's what I want you to remember. We talk about the triple aim. It's as if these things sort of are independently functioning units, but they're not. I think the American dream is universal access to high-quality, affordable care. But to have universal access, you need affordability. The barrier to access is affordability. Even today with the Affordable Care Act, if it goes forward, affording the Affordable Care Act is the problem. Not its design, not its merit, not its lofty goals. It's affording it. And the only way to make healthcare affordable is to improve it, not to cut it. So if we want universal access, it begins with the creation of an improvement methodology where you can look at some aspect of your clinical service and make it better by figuring out some measures that everyone understands, complication rates or, death or whatever. I mean, some service lines won't lend themselves to that. You can figure out 2 or 3 things by which you can say, we're really good at this. C-sections, or VBAC, or you pick them. But suddenly you engage the workforce in a way that line days never did. Just to browbeat people into line days. You don't have to browbeat people into this, they get it. And you engage everybody in a value stream. I told you the orderlies are responsible for nearly a percentage point reduction in mortality from acute myocardial infarction. The environmental services people are responsible for a lot of that work on bloodstream infections. They actively participate in root cause problem solving. You raise the level of play of the whole organization who feel like they come to work with with an important objective. It's not just a job, it's a calling. And the ideas then you share them with that team. It's really a good way to go. So I'll stop. I've got slides kind of talking more about methods, so I'm willing to go, how do you set this up? I'm happy to do that, but I think you're all smart executives. You know how to set it up. I can give you some ideas. You'll have the slides, or I can show you a few. What do you want me to do? You want me to show a few? If you don't like them, just So we call our improvement method Be Safe. We have 4 platforms at UVA, and I'll share them in a second. So these are our goals: to be the safest place to receive care, to be the healthiest work environment, to provide the highest level of clinical care. That's the clinical outcomes piece. We have a research mission, so we like to do that. To train the workforce in teams, so we have a program called Aspire, where nursing students and medical students and now respiratory technicians and social workers all train together in their 3rd and 4th year. It's a really cool thing. And then good stewards of resources. I would say if you do the top 5, the 6th follows. You don't have to worry about the finances. We had our best year ever financially this year. We put more people in the same number of beds than we've ever done with a higher acuity rate. Our case mix index is 2.2. That's average. That's not CMI. That's not Medicare. That's average. So very sick. We did 1,500 more operations. Same workforce. We admitted 1,500 more patients to our beds. Same workforce. How? People stayed fewer days with complications. And for the first time in our history, our cost per case did not go up year over year. Think about that. That we could actually flatten year over year the cost per case, as opposed to the 2 to 3%, 4%, 6% rise. That means that all the new revenue drops to the bottom line. You can make investments in safety systems, things like that. So these are our goals. We have 4 systems. I'm going to talk about Be Safe. The 4 systems are Be Safe, Be Well, Be Wise, and Be Smart. So Be Safe is the safety and performance improvement initiative. Be Well is us managing the 25,000 UVA employees. So we're self-insured for those employees. Our insurance premiums were going up 5 to 6% a year, just like every other employers. We were doing nothing about caring for our employees who were sick other than what we would do for anybody else. So we decided we would actively manage them. We would take over the management. We created care navigators, primary care involvement, and we basically have just completed the first 5,000 people in the project, and their cost year over year is down 5% compared to an 11% increase for the university as a whole. Actively managing our employees. This was the most profound experience of my life. So we're at UVA. We think we pay good wages. When we enrolled people in Be Well, in the first cohort of 1,500 people, we found 11 people who were working for me living in cars. We screened every one of the 1,500 people using the PHQ-9 for depression, PHQ-2, then PHQ-9. We found 13 people who were suicidal on the screen, all of whom underwent active intervention. it totally opened my eyes to the fact that you may pay a living wage, but life is pretty rough out there. Life is pretty rough out there. So these people are now under active management. They all have chronic conditions. We've gone from people with high blood pressure that were kind of at goal about 40% of the time to the first year results 80% of the time. My favorite is 362 people engaged in a weight reduction program. In a year, they lost 5,000 pounds. We didn't say use Jenny Craig, use Weight Watchers. We offered them a menu and we gave them coaches. So suddenly the workforce, when I say, and as Paul O'Neill always says, when you say in front of your annual statement, our workers are our most important asset, our people actually start to feel like they're our most important asset because we're actually interested in them. And we've seen a year-over-year savings. So Be Well is actively managing our workers who we're paying for, and we can invest in prevention, wellness. We borrowed something from the Cleveland Clinic called Stress Free Now, which all of our operating room nurses participate in, a place where there's a lot of stress. So we see people going from high levels of stress to low levels of stress using a cloud-based technology. So Be Well is about worker wellness. Be Wise is about respect, respect in the workplace. Our organization was very hierarchical. There was the boss, and everybody reported to the boss, and everybody's boss had a boss, and very, very, very hierarchical. Lots of instances of disrespect. And we had to create a circumstance not in which we aspired the value or espoused the values, but rather where they were seen leaders practicing the values. So everyone could recite the institution's values, but it was really hard to see examples of it. So what we did was we call out every week a great example of workers showing respect for other workers. We illustrate to people what respect means. We don't describe it as Webster describes it, right? We illustrate what it means to show respect. And in the wake of August 12th, I can tell you this is extremely important, that workers feel safe and respected. So that's Be Wise. I will tell you, it only happens when you can give concrete examples about what you mean by respect. Talking about it doesn't work. You have to show examples. And then we have a part of Be Wise that involves in trying to restore people who have had disrespectful engagements. But real-time reporting of disrespect. So if a surgeon yells at someone in the OR, that is managed today by a trained person who intervenes in the circumstance on communication skills. Today. No later than tomorrow. And then if people are recurrent, they go through a different set of training. But you need examples of what you mean by respect, and then you need an intervention when people don't act respectfully, because there will be occasions in stressful environments where people don't act respectfully. It's the nature of our work. I understand that. You just can't continue to do it. You have to learn how to do it. And you know those orderlies that I talked about in the OR? Most of whom in our place are people of color. They're often the subject of disrespectful comments. Why the hell can't you get this patient into the room? Now the communication is, can you please help me save this man's life by placing him on the operating room table? So that's the kind of, that's Be Wise. And Be Smart is the idea of the application of patient safety methodologies to clinically published work. So trying to write up some of this stuff so that we can kind of categorize it a little bit. So those are the platforms. Here's the 5 things that I learned from Paul O'Neill and from the value capture team that changed the way I thought about my role as a leader. The importance of actionable data. Data that people can understand, thus clinical outcomes. Solving problems in real time, I cannot emphasize enough. 2 hours of my day, not today, but 2 hours of my day every day is spent in actively solving problems with frontline workers. An hour in the situation room and then an hour Gemba walk. And all key executives in the organization, the CEO of the hospital, the chief financial officer, the chief HR person, the chief nurse, the chief medical officer, the chief quality officer, the dean are responsible for doing the Gemba walks. And your job is to go out where there was a problem yesterday and make sure the workforce has what they need to fix it today. And if not, to report back. So 2 hours every day from 10 to noon, blocked out to hear situational awareness, to understand events that went wrong yesterday, and to actively engage in the improvement process. It is the 2 most valuable hours I spend a day. I actually feel like I'm contributing something to the organization. Now, I don't know whether they think I'm contributing something, but I actually feel like I'm contributing something. Doing the right thing, the economically good thing, I talked about that earlier. There is not one improvement method that I've seen that hasn't yielded a demonstrable financial benefit. Solving for the right problems, this is the hardest thing for leaders because you're constantly presented with symptoms, not the root cause of the problem. And you've got to use the 5 whys to understand what it is you're solving for. And then this idea of the orderly or the environmental services person, that you're only as good as those people. You are only as good as those people on the front line every day creating those critical things. So Be Safe is this idea of us becoming a high-performing organization. We use lean. I'm agnostic as to what the tool is. I do think you need a disciplined problem-solving approach. You need a language that people can speak. We don't speak Japanese. We speak English, but we use the ideas. And it's this idea of pushing this through the organization. So when Value Capture was with us, they started this program with us. We've now trained 1,725 frontline staff in lean thinking. We have 26 unit-based leadership teams that are comprised of a nurse and an MD, 9 leadership coaches that are lean trained that are working with each of those dyads every day to help solve problems locally. Every unit has their dashboard publicly displayed, so you can go to any unit in our hospital and see how many HAPUs they've had this year and what the explanation was. And there's a publicly friendly way in which we discuss that with people. Darden Business School is affiliated with the University of Virginia, and the way we do the economics of this is we have 4 Darden Business School students that actively do the cost accounting measures to prove that what we just did was worth it financially. This was an idea that Jeff brought to us, that I actually have a super coach, someone that's assigned to me to keep me on message, to make sure I'm using my chime in a value-added way, to caution me when I'm not using respectful ways to communicate with people. You know, you always think you're respectful, but sometimes the way you say things, certain people don't take that way. So I have someone constantly reflecting on me and my performance. The daily real-time problem solving is really key. And then when you have big problems, sometimes it doesn't get done today, and we have these 90-day coalitions, very similar to Theta Care, where you just go deep into something for a period of time to try and get a lot of the value stream mapping around the clinical services, like the coronary bypass surgery needed a 90-day coalition to redesign that. You just weren't going to fix that overnight. But a bloodstream infection yesterday, today in our organization, you should fix that overnight. You know, this is just A3 problem solving. I think you guys all know this, that if you're familiar with lean. We're charging it forward here. If you're familiar with lean, this is the idea of problem statements. Everybody in our organization uses A3 problem solving today. So we have a compendium of problem solutions that are done with the same language. What's the problem? That problem has to be defined to root cause, the 5 whys. What's the current condition? What's the target condition? Who, what, by when? And what are the resources that are needed to complete the project? So we have literally a compendium of these problem-solving sheets done on an 8.5 by 11 paper in the true A3 method, and this was taught to us by Value Capture. The same language, everyone's speaking the same language. And then this is the value proposition, or the Shingo house. What are the core values the organization has? What are the implementation activities that are currently ongoing in the organization? Daily dashboards. This is one on sepsis. So one of the leading causes of death, you saw that reduction in death, is in-hospital sepsis. So we were able to dramatically reduce our in-hospital deaths by looking at early warning signs of sepsis. Frontline engagement, we put engagement scores up on everyone's Shingo value stream map up on their units, so that everybody can see where they are in terms of engagement. So just visible all across the organization, the problem-solving capability. This is now all on, we used to do this, hang these up on the wall, just like this. Now we actually have big TV screens on each unit, and the results flip through on a rotating basis. So that you can actually watch live what's happening on a daily basis. So at 7 a.m., when the team comes in, the first place they go is here, and they look at the live update of events that happened overnight across the organization. And then this is the idea of leader standard work. Everybody goes out and every day to a Gemba walk to go see what happened and what the progress is being made on a unit. And so the entire frontline staff then have 45 minutes with me to tell me about their work and to tell me what their needs are and how those needs aren't being met and what they need to make their work go even better. Now that oftentimes leads to other interesting conversations. So, you know, when you're the CEO and you go up there, and I want to say one other thing. Everything I showed to you today is about 15% of the opportunity. You say, oh my God, look at all those results. I think it's 15% of what we're capable of. I'm serious. This is only 15%. But we're getting better at it. We're able to take on more stuff. It takes time. But if you think about the magnitude of the opportunity, it's significant. But I'll go on a Gemba walk. The other day, I went up to the digestive disease unit where we have a big liver transplant program. We have a lot of patients with cirrhosis. So as you might imagine, first thing the director of the liver transplant program says, I need more beds. Can't get my patients in. Can't get my patients in, can't do transplants to help them. I said, well, you know, I see that your volumes are up year over year. And I said, but, you know, quite honestly, we can't make more beds. That's a hard thing to do. It's a capital intensive thing to do. He goes, well, you know, we need to build a new bed tower for liver transplants. I said, well, maybe, but how about over here on your dashboard where the readmission rate on your unit is 22%? That means every 30 days, 1 in 5 people that leave here is coming back. What if we reduce that in half? How many beds does that equal? I said, so why don't we see if we can fix the readmission rate before we build a bed tower, right? That kind of logic, you know, and see if you can find other ways to solve the problem. But you know, if you're the leader, people will constantly come to you with capital intensive projects, and the discipline is to say, well, that may be true, but what if we did this? What if we solve for this first? So their readmission rate's now down to about 17%, and suddenly the pressure on beds a little less, right? No more, didn't hire any more people, didn't have to spend more on stuff, just using the valuable resource in a more efficient way by identifying what the problem on the digestive disease unit was, which was readmissions, not beds. It's that kind of discipline. But when you go out there as a leader, you're going to be all kinds of great things people will come up with, you know, that they want to sell you for the 45 minutes that you're there. But if you use a disciplined way to think through the problem, you can usually work pretty collaboratively. So those are the ways we kind of built the system. These are just the dashboards I showed you every day on my phone. Here's some of the financial returns. So this is actually before last year. So 58 fewer bloodstream infections, 63 fewer urinary tract infections. The Darden people say that was worth $2.6 million. This is in 1 year. 109 fewer pediatric infections in our neonatal ICU, $4.2 million. There's a huge opportunity in neonatal medicine, huge opportunity. 53 fewer sepsis deaths, $1.83 million. 36 fewer falls, $82,000. This is patient falls. 46 fewer pressure ulcers, $1.6 million. 95% reduction in stockouts, you know, nurses not having what they need. Probably 3.2 million in supplies, and this is data Jeff helped us generate, 29,000 hours of nursing time. Nurses running around trying to find stuff that they didn't have. You know, one of the favorite stories I had at UVA, I got UVA or Penn, but it was such a apocryphal story, I got to tell you. Nurses are incredibly resourceful with supplies, and when they don't have them, they are like, the best squirrels in storing things away. So we're on an epilepsy unit in our neurology floor, monitor patients with epilepsy. And there were never enough monitoring leads. So this nurse got so creative that he basically stuck packages of monitoring leads up underneath the ceiling tiles so that he would constantly know he had his own supply of monitoring leads. Now, God knows when they expired. God knows what's in the ceiling, right? But should it really be that hard to be able to give an epilepsy patient monitoring leads? But that's a supply chain problem. That's a value stream map. That's a customer-supplier relationship. That is the quintessential application of lean, con-man systems, knowing when stockouts occur. So we redesigned some of this work. We had to reinvent it. We didn't have the right people in place. You have to give people the tools, but sometimes people aren't necessarily game, and so we had to make some changes there. But now we're getting some good response. And then 96 fewer worker injuries. That I call priceless, right? When your workforce is spending fewer days away and not getting hit by patients. And so how do we prevent nurses from being hit? We do a risk assessment of everybody admitted to the hospital. Now, I will tell you, you don't have to do a risk assessment on the OB unit, right? There are about 5 units in the hospital where demented, delirious patients, intoxicated patients, opioid abused patients come in. The risk group. So what you do is identify the risk group, and then you identify the patient who is a risk to hit a nurse. And then no nursing activity is done in that room without a partner. So a nurse is not asked to go in and give a delirious patient an injection of insulin without a partner to help make sure the patient can be controlled while the insulin's being given. You say, oh my God, what a waste of valuable resource having 2 people do the work of one, until you get hit by a patient, right? More than 100 nurses socked by patients. We had a nurse break her wrist, right? A patient grabbed her wrist, broke her wrist. You can't have that stuff and say that actually your workforce matters to you. So that's the way we deal with, that's the current condition. That's the system we put in place. Now we're testing it. How many of those injuries can we really reduce? I'll give you another example of where we totally screwed up. Splashes, right? Stuff to the face, all kinds of stuff flying around. So one of the OR techs said the way to fix this is everybody in the organization, when they're going into a patient room to do something with a bodily fluid, needs to wear goggles as well as the rest of the PPE. I said, boy. Okay, so what's the root cause of the problem? To my mind, the root cause of the problem is why are there splashes? Why is there stuff flying around? That's my problem. They said, no, stuff always flies around. I said, really? So you mean to tell me it's humanly impossible to keep the ventilator tube from detaching so that sputum flows around? They say, it's humanly impossible for us to do that. And I said, well, I don't necessarily agree, but let's try your way. So now everybody wears goggles, and we've reduced exposures, but not splashes, right? So people still get splashed. They don't just get splashed in the eye. And then, of course, they get splashed, and now they get splashed in the mouth, so now you say you cover everybody's mouth. You could just go endlessly on through this, right? So now we have a workforce, all of whom wear goggles, but we still have splashes. It's an example of how solving for the wrong problem gets you a bunch of people wearing goggles, but not a lot of people without splashes. So now we're back to, is it humanly possible to keep a ventilator tube from being disconnected so sputum doesn't fly around? All right, that's it. My last slide. I could keep going, but I won't. Okay, that's really the last one. Okay, so we have a conversation now.